Hello and good evening. My name is Gesine Visse, and I'm going to talk a little bit about neurotrophic factors for Parkinson's disease and the most recent developments that are in the field. These are my disclosures. So in the field of Parkinson's disease, perhaps the most unmet medical need currently is a therapy to slow down or to stop the underlying disease progression. And neurotrophic factors are a possible candidate for that due to their ability to confer neuroprotection and neurorestoration. So growth factors are endogenous proteins. The approach in Parkinson's disease especially is based on their disease-modifying potential. And there have been many growth factors tested in preclinical animal models of Parkinson's disease, but only very few actually have been translated to the clinic. I will focus during my talk on especially 3 different growth factors that have been recently developed or have been developed for a while, but have been in recent clinical trials. And that is GDNF, glial-cell-line-derived neurotrophic factors, PDGF, and CDNF. So GDNF stands for glial cell line derived neurotrophic factor. This is an endogenous survival promoting protein that is quite rapidly metabolized. GDNF belongs to a growth factor family that includes also other growth factors and binds to several receptors, a growth factor receptor alpha-1 and alpha-2, and it's also using RET as a co-receptor. There are extensive preclinical data supporting the effect of GDNF in Parkinson's disease, showing restoration of the nigrostriatal system and also behavioral recovery. So I just want to share some data from clinical trials with you, just showing the biological effect and also the possible clinical effect of GDNF in clinical trials. So from the early open label trials of intraputaminal GDNF delivery, there's actually evidence for target engagement of this growth factor. Here we can see a PET scan, a flow Doppler PET, and there is some improvement around the tip of the catheter. This was a study where there was just one catheter going into the putamen, and you can see here the arrow pointing to the flow Doppler PET before treatment, and also after treatment you can see the red color around the tip of the catheter actually indicating increased F-Dopa PET signaling and possibly sprouting of dopaminergic fibers. There's also some data from one patient who had come ad mortem and who was part of one of the clinical trials, the early open label clinical trials. This was a patient who had received a unilateral infusion of GDNF, and you can see here, this is a tyrosine hydroxylase staining. There is the brown color in the putamen of the infused site, clearly showing that there is an increase in dopamine fibers indicated by an increase in tyrosine hydroxylase staining. And that is very similar to what has been shown in animal studies using the same growth factor. So there's quite a bit of a rocky road regarding GDNF, but it has been again in clinical trials just recently, and this was an academic-initiated clinical trial, a randomized, double-blind, placebo-controlled, single-centered trial, testing GDNF using a repeated treatment paradigm. So there were 41 patients included in the study. They all had moderate Parkinson's disease defined by a Hoenig stage between 2 and 3 in the off. And these patients received bilateral intraputaminal infusions of GDNF or placebo every 4 weeks for a duration of 40 weeks. And then this study was actually completed with another part, which was an open label extension study for another 40 weeks. And I'll explain a little bit how this was done. What is quite interesting with this type of study here is that there was a convection enhanced delivery system used to increase the putaminal coverage of the growth factor. So the primary outcome parameter of this trial was to assess the change in UPDRS update from baseline compared to line is denoting the GDNF patient, and the blue line is denoting the placebo patients. And you can see that there was no significant difference at 40 weeks at this time point. So there was quite a strong placebo response in the study, and the primary endpoint was not met in the study. However, doing a post-hoc analysis, the authors actually looked at the patients in a little bit more detail, and they identified the number of patients who had got a clinical significant response of more than 10 point in the UPDRS part 3 motor score in off. And the number of patients was significantly larger in the GDNF group here in red compared to the placebo group in blue. There were no responders that had more than 10-point improvement in the UPDRS and the placebo group, but quite a number of responders in the GDNF group, indicating that there is a effect happening, but it did not reach statistical significance on a group level. And I think this is really important to look at in clinical trials before we actually discard a clinical treatment. So here's also a sign of target engagement in the flow dopa PET. Very clearly, you can see the baseline PET on the top panel, placebo at baseline and placebo at 38 weeks. There was no increase, rather a slight decrease in maybe flow dopa PET. And in the lower panel, you can see GDNF at baseline. This is the patient who had received GDNF, and then at 30 weeks, you can see a very clear increase in the fluodopa PET, especially in the posterior putamen. There's almost a complete restoration of the dopaminergic fibers in these patients, which is quite impressive, I have to say. Anyhow, this did not correlate to the clinical data, at least not on a statistical level, even though if you look at a patient level, you could actually see that it did correlate with clinical improvement. So the authors actually did an extension trial for another 40 weeks. And this time, the patients who had received placebo before also received GDNF, but they were not blinded to the, they were still blinded to the previous treatment. So the study wasn't unblinded at this stage. And what you can see here is that the placebo group now also quite strongly responds to GDNF, and the curves are actually approaching each other. However, the endpoint here was the difference between the two groups at 80 weeks. That's 9 months plus 9 months extension. And again, there was no significant difference because both groups actually improved by about a third in the UPDRS score in off at 80 weeks. However, what I really want to point out in this graph is if one had not unblinded the study or had not switched the placebo group to a GDNF group, but continued with a blinded placebo-controlled design, maybe for another 9 months, the placebo group would have leveled out, and maybe there would have been actually a significant difference at the end point if the study design had been in the way that one waits 18 months instead of 9 months. I think this is also important to consider when we talk about study design and why clinical trials actually fail when they come to phase 2 efficacy. However, this was not being done, and the study is published as having not met the primary endpoint. Similar results we can see in other clinical parameters here, the change in total off time per day. Also, we can see a slight placebo response, but actually not as strong as in the UPDRS motor score. And then once the placebo patients get the GDNF treatment, the two curves actually get closer to each other. So the reduction off time was about 1.5 hours in the GDNF group, and about 0.8 hours in the placebo group that was switched in the second part of the study to GDNF. It's also quite interesting that the increase in levodopa equivalent dose at 18 months versus baseline was significantly less in the GDNF group when compared to the placebo GDNF group. That means that these patients actually did not need as much medication as the placebo patients at the end of study. It's also an indicator that there is actually something happening also on a biological level in the patients. Similar here, this is again an on time. Again, we see that the GDNF patients quite early have again an on time. It's about 1.6 hours on time per day, which is quite substantial during this stage of the disease. And it's about half a day in the placebo GDNF group at the end of study. However, this was not significant. So what can we conclude from this double-blind placebo-controlled phase 2 trial? The study did not meet the primary endpoint, and the question is, maybe the study population wasn't ideal for this type of study. The disease may be too advanced. Also, maybe the dose was too low. The dose in this study was about 3.5-fold lower than the one used in previous open label trials. Possibly the follow-up time was too short, as I illustrated. If one had waited maybe another 9 months, continuing with the placebo group, the groups would have separated enough to cause a statistical significance. So one really has to consider the magnitude of a placebo effect, especially in trials like that are very invasive surgical paradigm. There's usually quite a strong placebo effect in this type of trials. So what is the future of GDNF? Where are we going from now on? So there's a study ongoing at the moment, which is a viral vector GDNF delivery. It's a phase 1 trial from the National Institute of Neurological Disorders and Stroke in the United States. It's a single center trial. It's open label, also a dose escalation study using 4 different doses. And the patients in the study are very advanced. They are hernia stage 3 to 4. The GDNF is delivered bilaterally using also a convection enhanced delivery system, and 24 patients are included in the study. The endpoints here are safety and tolerability at 5 years. So the study is ongoing. It's published at the website clinicaltrials.gov, and it's estimated to be completed by the 1st of February next year. So we're looking forward to see what this study is showing, but again, it's a phase 1 study. It's not a phase 2 study yet. So what happens otherwise? There are 2 other approaches in the field that are actually leaving the cell autonomous approach and are working more towards changing the microenvironment of the cell or towards having a multimodal approach in the system. One is PDGF and the other one is CDNF. So PDGF stands for platelet-derived growth factor BB. It's a endogenous growth factor, a dimeric like a protein, and it binds to PDGF receptors. There are several ones. The highest affinity of PDGF-BB is to platelet-derived growth factor beta. We know about PDGF that it has a role in angiogenesis. It's a mitogene for mesenchymal cells, for smooth muscle cells, and also for pericytes. Pericytes are perivascular cells lining the entire microvasculature of the brain. So what is the mechanism of PDGF-BB? The preclinical studies suggest that it increases cell proliferation, and that can be blocked with the mitosis blocker. It has also shown that there's an increase in the number of tyrosine hydroxylase positive cells in the substantia nigra pars compacta, again TH denoting dopaminergic cells. That has been shown in several animal models. There is an increase in DUT binding, dopamine transporter binding in the striatum, and also a very clear behavioral effect in animals receiving PDGF-BB as long as the lesion is a partial lesion. We have also worked with this growth factor in preclinical studies, and what we see is actually that there is a normalization of vascular changes. So in Parkinson's disease, what we see is an activation of pericytes quite early on in the disease, and also a likely compensatory angiogenesis. And when we give PDGF-BB, these vascular changes are actually normalized. So what we propose is actually a dual mechanism of the regenerative effect of PDGF-BB and Parkinson's disease. And that is that the PDGF likely works via pericytes by normalizing vascular changes, keeping the pericytes at the microvessels, but also by affecting the secretome of these cells and thereby maybe having an indirect effect on the pathological microenvironment of dopaminergic cells. So what we believe is that parasites at the blood-brain interface are key players for the neuronal microenvironment and play a role for inflammation, vascular dysfunction, and also neurodegeneration. So PDGFBB has now come into clinical trial and has been entered the first in human clinical study a couple of years ago. This was a very small trial. Only 12 patients were involved in this clinical trial, and it was performed at 2 different sites here in Sweden, at the University Hospital here in Lund and also at Huddinge Karolinska Hospital in Stockholm. These data are all published. PDGF was delivered in a different way here. It was delivered into the ventricles using an abdominal pump, where the growth factor can be injected through a small membrane through the skin, and then it's delivered via a catheter directly into the ventricles. So the patients were treated for 2 weeks with the growth factor and then followed for another 3 months. And there was a placebo group in this trial as well. So what we can conclude from the PDGF trial is that there were no adverse events or serious adverse events that were related to the investigational product at any dose tested. All patients, including the placebo patients, improved with about 4.5 points at the UPDRS motor score over 3 months. And all other parameters such as depression, cognition, quality of life were similar before and at the end of the study. Also here, there were signs of target engagement. This time we used a PE2 PET, which is the more specific dopamine transporter ligand. And you can see in the upper panel, this is a placebo patient at baseline and post-treatment. There is no change, if at all, maybe a slight decrease in signal. However, this is one of the high-dose patients at baseline, and you can clearly see there's an increase in the dopamine transporter binding after 3 months, showing that actually the drug reaches its target in the putamen. So let's now move to another growth factor. This is CDNF, which is ongoing right now and under investigation in the field. It's cerebral dopaminergic neurotrophic factor, and this factor has been discovered and developed by Professor Mart Samer from the University of Helsinki. CDNF is one of the growth factors that has multiple different mechanisms. It promotes normal neuronal function by reducing endoplasmic reticulum stress, reduces alpha-synuclein aggregation and toxicity. It can promote neuronal survival through proteinase kinase B. It can suppress production and secretion of pro-inflammatory cytokines by glial cells, and it also supports the long-term maintenance of neuronal functions by modulating gene transcription. So it's not just affecting neurons directly, but it has multiple different mechanisms, which actually may be quite advantageous in the context of Parkinson's disease. So CDNF is supported by a large number of preclinical studies, and I will not show these ones here, but I will talk a little bit about the phase 1/2 randomized double-blind placebo-controlled safety and tolerability study that is ongoing at the moment. So this is a study actually applying CDNF intermittent and bilaterally into the putamen of patients with moderate Parkinson's disease. It's a study that is sponsored by Herantis Pharma and Renisho. Renisho stands for the device and Herantis for the product. And it's performed at Karolinska University Hospital in Stockholm, here at Skåne University Hospital in Lund, and also in Helsinki in Finland. And we are using 2 different PET centers in the study, one at the Karolinska Hospital and the other one at Turku PET Center in Finland. The study has also gained support from the Horizon 2020 program by the European Union. So the study design of the study, which is called TREAT-ER, Treater. There are 70 patients found Parkinson's and tolerability of intraputaminal CDNF. The study has 3 different phases. The main study is for 6 months. It's a blinded phase, and here we have a placebo group, a mid-dose and a high-dose group. And then after 6 months, the study was unblinded and moved over to an open label extension. And that open label extension, actually the patients who received the vehicle in the 6 months previous study were allowed to get also active treatment at mid-dose or high dose in a randomized fashion. At that time point, everybody was unblinded, and the patients were treated again with monthly infusions for another 6 months. And then the patients are followed up to 4 years at another safety measure after that. And during that time point, they do not gain any infusions. So the system used in this clinical trial is a delivery system where the growth factor is directly delivered into the parenchyma, into the putamen, as you can see here on the upper picture. And the way this has been done is by implanting a catheter system whereby 2 catheters go into each putamen, so 2 on each side. And this is connected to a little port, which is mounted onto the skull. And then an adapter can be adjusted to it, and the growth factor delivered once every 4 weeks. This looks like that. So if you this is all implanted subcutaneously onto the skull, and then the catheter is going directly into the putamen. And then there is a little port system, and it looks like that on a patient. So it sits behind the ear, it's mounted, and there is a small membrane. And onto this port, there is a adapter system attached each time the patient comes for infusion. So what are the preliminary conclusions from the CDNF study? So the study has just been completed and the publication is in preparation. Some of the data have been presented at international conferences. The primary safety endpoint in this study was met. There are some signs of biological response and clinical response in individual patients. Again, this is a study that is designed for safety and not for efficacy. And the company has decided to develop CDNF further, but to choose a less invasive route of administration to access also early stage patients. So the intracerebral delivery system is quite invasive and makes it often very difficult to get ethical approval for this type of studies, which is of course a problem because one wants to target early stage patients. If you test a neuroprotective or neurorestorative treatment, you want to go early when there's actually when there are cells and fibers left to rescue. But the invasiveness of the procedure itself often makes it very difficult to get approval for this type of trials. So the company is exploring a different application route, and also is exploring if there are genetic subtypes of Parkinson's disease that actually may have a special benefit of this type of treatment in the future. So I just want to conclude my talk with some thoughts about what makes it so difficult to translate growth factors to clinical trials. What are the caveats of clinical trials? So why do we often not meet the primary endpoint when it comes to double-blind placebo-controlled trials, even if there is very convincing preclinical evidence and also excellent safety data, often with indicators of actually clinical effect in open label trials? So what is the reason for that? So what we need to do is we really do need to inspect trials for a clear proof of principle evidence. And that is not only on a group level, that is also on an individual level. So if we do have patients who are improving clinically and have a clear sign of target engagement and maybe even signs of improvement in PET, then this needs to be taken seriously as I believe that is the proof of principle that there is a biological effect happening and that there is a potential of the intervention to achieve that effect if maybe conditions are optimized in the clinical trial. So we have to identify the reasons for failure. So we have to look at trial design and see, is the trial design faulty? Because in the end, we are deciding about the go or no go of a maybe very promising clinical intervention based on a statistical analysis on predefined endpoints. And that can be good and bad at the same time. So we need to look also at the placebo effect in these trials because they can actually mask a very good clinical effect if we do not wait long enough. Placebo effects are usually quite strong, but they do not last forever. So often one has to wait long enough, as I tried to illustrate in the GDNF study. If you wait long enough and maybe keep the placebo group blinded for a longer time point, the study, the lines will actually separate in the end and maybe even give a significant effect on a group level. I think it's also very important to carefully select the patients we are investigating. The more homogeneous the population is, the less noise the study will have, and the more evident results will become. And of course, a key question when we talk neuroprotection is the disease stage. So the question is Parkinson's disease too advanced when we're actually employing neurotrophic factor treatments? So we have to argue for earlier disease stages. And I think this is extremely important that we convince authorities like the FDA and the EMA that it's almost unethical to test neuroprotective treatments in late stage patients, even if it's a phase 1 trial, because we know that it's extremely unlikely that these patients will have an effect just based on biological principles. And if we recruit those patients to phase 1 trials because these trials are considered too invasive for earlier stage patients, then I think it's unethical because every patient will join a clinical trial with the hope for some kind of clinical effect. And also very important is that we wait long enough for the clinical effect to be visible. And that means when we look at neuroprotection, we need to wait much longer than compared to when we look at a symptomatic clinical effect. For instance, when we test a new dopaminergic drug, because it's going to change the slope of this disease progression, and it's not going to give a symptomatic effect in the same to the same degree as other interventions may actually do. So we need to wait long enough for the effect to be visible, and we need to have measures that actually measure what we are aiming for. And it's a long discussion in the field, of course, what measures are there? Do we measure what we should measure? And are these measures sensitive enough? And I think it's really important to consider that. So we need to carefully select clinical outcome parameters in our clinical trials. I also want to mention that we need to be aware of the statistical power we are losing when we're comparing multiple groups. So every dose escalation will introduce multiple groups, and that means that we have to use ANOVA tests instead of t-tests, and that will also mean to lose statistical power. And again, that is connected to the meeting the primary endpoint or not. And meeting the primary endpoint or not in efficacy study is connected to whether a potentially promising treatment has a chance to go forward or not. And at this very moment, we do not have a single treatment to offer our patients with Parkinson's disease that will slow down this disease progression or even lead to some kind of neurorestoration. So I really urge everybody to think very careful about study design. So we talk about type 1 errors and type 2 errors, and type 1 errors are usually connected that we are concerned about errors in clinical study design, and that is when ineffective interventions intervention appears effective, and we may actually go forward with a treatment that actually does not have a robust effect. But type 2 errors are means that when a truly effective treatment is discarded due to poor study design, and that is at least as devastating as type 1 errors. So I want to finish my talk with this little cartoon, which I hope will really illustrate the field of neuroprotection and trials and growth factors. So on this cartoon, it says this little man here being on the floor searching for something. And he says, "I'm looking for my quarter I dropped." And the policeman says, "Did you drop it here?" And he says, "No, I dropped it 2 blocks down the street." And the policeman says, "Then why are you looking for it here?" And the man says, "Because the light is better here." So he's looking under a lantern for the quarter he dropped somewhere else. So I want to translate this into neuroprotective trials. He says, "I'm looking for a neuroprotective treatment. So do you think it works in advanced patients?" And he says, "No, they don't have enough cells left." And the policeman says, "Then why are you testing this treatment on advanced patients?" And he says, "Because the FDA and EMA only approves late-stage disease." So please do argue for early disease stages. And this is what I want to conclude my talk with, and I'm happy to take any questions. Thank you for your attention.